So it's a huge honor for me to welcome you to this webinar on organ protection that is linked to a series of papers that were published in December last year in A&A. I chair the webinar together with Professor Markus Hollmann. He's the chairman of the Department of Anesthesiology at the University of Amsterdam. My name is Alexander Zarbock. I'm the chair of the Department of Anesthesiology, Intensive Care and Pain Medicine. In the last couple of decades, anesthesia became very safe, as you can see here on this slide. Anesthesia-associated mortality is 0.0017%. However, hospital mortality after major surgery is 4%. The gap is quite big, and the question is, why do the patients die? Several studies demonstrated that patients after major surgery often have complication and subsequently develop organ dysfunction and organ failure. And this is the reason why patients die in the perioperative period. The most common complications, as you can see here, are sepsis, pneumonia, acute kidney injury, and bleeding. If you want to improve patients' outcome, then we have to prevent these complications. In the next 45 minutes, we will hear 3 lectures covering different topics. After the talks, we will have enough time for questions. The first speaker, as you can see here, is Professor Melanie Meersch. She's an anesthesiologist and intensivist by training and an expert in the field of acute kidney injury. She will talk about perioperative renoprotection clinical implications. The second talk will be given by Professor Benedikt Preckel. He's professor of anesthesiology at the University of Amsterdam, and he's going to talk about perioperative cardioprotection clinical implication. And the last speaker today is Professor Markus Schultz. He's professor of experimental intensive care at the University of Amsterdam, and he will talk about perioperative lung protection clinical implication. And with this, I will hand over to Melanie Meersch, who will give the first talk. Melanie.
Dear audience, first of all, I would like to thank Professor Hollmann and Professor Zarbock for inviting me to this very important webinar on organ protection in the perioperative period. I believe that there are a lot of possibilities to prevent organ dysfunction in this setting, and these need to be emphasized in order to improve patients' outcomes. So I will focus on the kidneys and on kidney dysfunction. My topic is Perioperative Renoprotection clinical implications. And here you see my conflicts of interest. I received lecture fees from these companies. Acute kidney injury is a frequent complication in the perioperative setting. You see that the incidence is approximately 12% among all the surgical procedures, whereas in the ICU setting, approximately every second patient suffers from this clinical condition. And here on the right side, you see that the higher the severity of acute kidney injury, the higher the mortality rates, which reach up to 60% in critically ill patients with severe acute kidney injury, also KDIGO stage 3. Acute kidney injury is a syndrome that is not only associated with higher mortality rates, it is also associated with adverse outcomes such as delirium, infections, bleeding, chronic kidney disease, chronic dialysis dependency, as well as cardiovascular diseases. And therefore it is surprising that a cross-sectional study has demonstrated an estimated number of unreported acute kidney injury rates of 74%. And this emphasizes, on the one hand, that we need more focus on the kidneys, but on the other hand, that we urgently need preventive strategies to reduce the occurrence of acute kidney injury in order to improve patients' outcomes. Today, we know that acute kidney injury is a continuum that starts with normal kidneys and ends up with organ failure. But in the course towards organ failure, there are different steps in between which need to be focused. We have higher susceptibility resulting from underlying comorbidities, kidney stress or damage. Then we have a reduction of the glomerular filtration rate, increases of serum creatinine and urine output, which equals acute kidney injury. GFR reduction and acute kidney injury are clinically manifest, which can be detected with the classical markers, serum creatinine and urine output. Acute kidney injury is currently defined by the KDIGO criteria, which classify 3 stages of acute kidney injury. And these stages depend on the increase of serum creatinine and or the decrease in urine output over a certain period of time. However, the changes in the classical markers demonstrate a reduced kidney function, which means that the kidneys are already damaged. And at this stage, preventive strategies are pointless. We need to start preventive strategies at an earlier stage. New renal biomarkers have the capability of detecting earlier stages of kidney stress before kidney function is reduced. And at this stage, preventive strategies are meaningful. So several new renal biomarkers have been evaluated in the past, but none of these was sensitive and specific enough to find its way into daily clinical practice. To this date, the most promising biomarker is the combination of tissue inhibitor of metalloproteinase 2 and insulin-like growth factor binding protein 7. This biomarker has been detected in the so-called SAPPHIRE trial and has been validated in several clinical settings. These data demonstrate a high predictive value for the occurrence of acute kidney injury. Receiver operating characteristic analysis consistently demonstrated an area under the curve of 0.8 or higher, meaning that patients with elevated levels have kidney stress and are at high risk of developing acute kidney injury. To understand the underlying mechanism, TIM2 and IGFBP7 are both markers of the G1 cell cycle arrest. Under normal circumstances, renal tubular epithelial cells undergo cell cycle arrest to be sure that the DNR is not damaged after replication. This cell cycle arrest, however, can be used in situations of cell stress to prevent cell division. And in this situation, you see here that TIMP and IGFBP7 are expressed. Another important finding is that TIM2 and IGFBP7 are not affected by chronic underlying comorbidities, as has been demonstrated, for example, for another biomarker, the so-called neutrophil gelatinase-associated lipocalin. Especially in patients with underlying chronic kidney disease, there was no difference detectable and underlines the robustness of the marker. In terms of prevention, different pharmacological options have been evaluated for the prevention of acute kidney injury, but without success. However, all these options were applied in patients with already reduced kidney function. The KDIGO guidelines recommend to implement a bundle of supportive measures in patients at high risk for AKI. And these bundles include the discontinuation of all nephrotoxic agents if possible, the insurance of volume status and perfusion pressure, the consideration of functional hemodynamic monitoring, the close monitoring of serum creatinine and urine output, the avoidance of hypoglycemia, and the consideration of alternatives to radiocontrast agents. How exactly patients at high risks should be determined is not specified in this guideline. And in view of the new biomarker findings, it is conceivable that a biomarker-based strategy for detecting patients at high risk for AKI to early implement the bundle may be effective. Several trials investigated such a biomarker-based implementation of the KDIGO bundle. The first one was the so-called PREVACI-1 trial, which was a single-center randomized controlled trial. And here it could be demonstrated a 15% reduction of acute kidney injury in patients undergoing cardiac surgical procedures. This was then followed by the second randomized controlled single-center trial, the so-called BIG-PAC trial, which was a trial where the KDIGO guidelines were implemented in patients undergoing major surgical procedures, and the results demonstrated 13% reduction of acute kidney injury. Then Engelmann and colleagues performed a quality initiative improvement using a similar biomarker-based strategy in cardiac surgical patients, and they found a relative reduction of acute kidney injury of 89%. And recently, the PREVACI-2 trial confirmed these results in a multi-center and multinational setting. Although the total rate of AKI could not be reduced and acute kidney injury was a secondary outcome, a significant reduction of moderate and severe AKI, which are the two main stages of acute kidney injury, which are more affected or which more affect patients' outcomes. This was demonstrated to be 10% lower than in patients, or AKI was 10% lower than in patients not receiving the KDIGO bundles. So in conclusion, such a patient individualized strategy using new renal biomarkers in combination with the different measures as recommended by the KDIGO guidelines are effective to prevent acute kidney injury. Considering the different recommended measures, it is conceivable that some measures may be more effective and more obvious than others. For instance, if nephrotoxic agents are avoided, these will obviously not harm the kidneys. Some variables do definitely per se not reduce the occurrence of AKI, as for example, the close monitoring of some creatinine and urine output. But let's focus on the others. One component of the bundle is hemodynamic monitoring and optimization. Walsh and colleagues have demonstrated that even short durations of mean arterial pressures lower than 55 millimeters mercury were associated with acute kidney injury. Salmasi and colleagues demonstrated that even higher MAPs, or mean arterial pressures of lower than 65 millimeters mercury, were associated with AKI. So it seems that not specific numerical thresholds are important for kidney perfusion, but individual thresholds, as there may be some patients, for example, with arterial hypertension, who may need higher pressures to keep an adequate kidney perfusion, as compared to patients without pre-existing arterial hypertension. Foutier and colleagues performed a randomized controlled trial and tested an individualized pressure target group as compared to a standard pressure group. And the results demonstrated significantly lower rates of acute kidney injury in patients of the individualized patient pressure group. So the KDIGO guidelines actually recommend individual blood pressure targets. In terms of fluid management, multiple studies noted the large variability of intraoperative application of fluid volume. It is known that fluid overload is associated with acute kidney injury and mortality. The study by Payen and colleagues, as well as the REMIFA study, are two of the many trials which have demonstrated this association, that fluid overload is associated with AKI and with adverse outcomes. A treatment of hypovolemia should definitely not result in hypervolemia. But studies on how to manage fluid administration have analyzed restrictive versus liberal fluid strategies, and it turned out that neither restrictive nor the liberal strategy is the correct way of treating. So the KDIGO guidelines recommend to avoid excessive hypo as well as hypovolemia. Another component of the bundle is the avoidance of hypoglycemia. Several reviews have focused on the association between glucose levels and acute kidney injury, but not only hypoglycemia negatively affects kidney function. Hypoglycemia leads similarly to more oxidative stress, to an increase in inflammatory markers, and to endothelial dysfunction, which consequently ends up with acute kidney injury or inacute kidney injury. So actually, it can be concluded that glycemic variability affects kidney function. Several trials have been performed to evaluate the ideal glucose threshold, and the landmark study, which was performed by Gret Vandenberge and colleagues, which demonstrated lower mortality rates in patients with glucose levels of 110 milligrams per deciliter or lower, could not be supported by other trials. Especially the NICE sugar trial demonstrated that a too tight glycemic control was associated with higher rates of hypoglycemia and higher mortality rates. Therefore, this strategy cannot be recommended, and the KDIGO guidelines recommend blood glucose levels of between 110 and 149 milligrams per deciliter. So I'm coming to the end of my presentation, and I would like to conclude the most important points of my presentation. Acute kidney injury needs more focus in daily clinical routine as it is associated with high morbidity and high mortality. Urinary biomarkers can identify patients at risk for acute kidney injury, and these biomarkers can be used for an individualized approach to implement the KDIGO bundles, which has been shown to reduce the occurrence of acute kidney injury. And although everyone believes that the bundles are already implemented in daily routine, this is clearly not the case. This survey has demonstrated that only 5% of the cardiac surgical patients, which is a cohort of patients at risk for AKI, only 5% received the complete bundle. So I hope that I could underline the importance of preventing acute kidney injury and the meaningfulness of implementing the KDIGO bundles in patients at risk identified by biomarkers, which is currently the most effective available option. Thank you.
Dear colleagues, welcome to this organ protection webinar. I am Benedikt Preckel. I'm anesthesiologist at the Amsterdam University Medical Center's location AMC in Amsterdam, the Netherlands. I will talk about perioperative cardioprotection and its clinical implications. I do not have any conflict of interest to declare regarding to this topic. When we consider different conditioning strategies, we have different time windows, a preconditioning, a per-conditioning, or a post-conditioning window, where we can induce either ischemic, remote ischemic, or pharmacological protection. But we also have to consider different mechanisms of injury, an ischemic injury, but also a reperfusion injury, which occurs just at the beginning of reperfusion after ischemia was stopped. There is a huge amount of experimental literature investigating the crucial elements contributing to cell damage and the possibilities of cardioprotection by conditioning. Some of them have recently been summarized in and published in Anesthesia Analgesia. We know that volatile anesthetics, noble gases, propofol, but also other medications that we probably use during the perioperative period are able to influence membrane receptors, thereby leading to intracellular changes of salvageable pathways like the safe pathway or the risk pathway, whereby channels on the mitochondria can be influenced, for example, the KATP channel or the MPTP, leading or inducing cardioprotection. And there were all early proof of concept studies showing that cardioprotection, for example, by volatile anesthetics, is also possible in coronary artery bypass graft surgery. These data showed that 2 times for 5 minutes applying sevoflurane as a preconditioning stimulus before coronary artery bypass graft surgery significantly reduced troponin release in these patients. These data were confirmed by other study groups showing that sevoflurane application reduces troponin release, probably depending on the manner of its application. However, when clinical outcome studies were performed, these were a little bit disappointing, and it brought one of them here, the data of the Myriad trial, which was a pragmatic multi-center trial in 36 centers in patients undergoing coronary artery bypass graft surgery who received either total intravenous anesthesia or a volatile anesthetic either before, during, or after extracorporeal circulation. And what you can see regarding the probability of survival, there was absolutely no difference between the two groups. Again, when it came to outcome studies, these studies were not able to show a significant difference for event-free survival or for the cumulative incidence of events in patients treated with remote ischemia or not. And the question therefore arises, what is the difference between the experimental and clinical proof of concept studies and the outcome studies? So there might be confounders and other clinical circumstances that play a role. Confounders can facilitate or inhibit cardioprotection. For example, a facilitator would be statins or probably opioids. And inhibiting cardioprotection can occur during by diabetes and other comorbidities, but also by use of different drugs like sulfonylureas or beta blockers. And it might be that the heart is already protected by short duration of chest pain, for example, by angina pectoris, or by short cross-clamped periods during coronary bypass graft surgery. And thus it could be that there is a limitation of the potential for further cardioprotection. We also have to consider that it's not only necrosis leading to cell damage. Necrosis, what we measured by troponin release, but there are other mechanisms of cell damage like necroptosis, apoptosis, and perioptosis, which may play a role when we consider outcome of our patients. And there is not only cell injury, but also injury to other structures like the coronary microvasculature. We could have microembolizations, states, intravascular cell aggregates, capillary rupture and hemorrhage, interstitial edema and capillary obstruction, impaired vasomotion, but also increased leukocyte adherence and infiltration. All these might contribute to organ damage. And therefore, it is suggested that there will not be the one intervention that leads to cardioprotection, but probably a combination, a multi-target strategy to reduce myocardial damage in clinical situation. To combine ischemic conditioning, for example, by remote ischemic conditioning with pharmacological protections and other physical interventions at different time points, thus during ischemia, at the beginning of reperfusion, late into reperfusion, or if we know when the ischemia occurs, for example, in cardiac surgery, also before ischemia. We could target and combine protective strategy against different cellular targets, the cardiomyocytes, but also non-cardiomyocytes, other cell types. We could target microvascular obstruction. We could target circulating cells like leukocytes. And we should think about combining inhibition of cell death pathways with the activation of endogenous pro-survival pathways. If we go back a little bit into the history of, for example, remote conditioning, we see that there was a describing of the phenomenon in the late 19th, and then demonstration of the effect in humans and in patients undergoing CABG surgery or having myocardial infarction. But if we look for the improvement in therapies during this period, we also see a difference in strategies. These are data from a Swedish registry in patients with ST elevation myocardial infarction and the key treatments from 1995 to 2014. And what you see in the beginning of this century, there was a huge increase in the use of primary PCI. And there was a huge increase in the use of dual antiplatelet therapy in these patients. And namely, the use of antiplatelet therapy might influence cardioprotection by different conditioning strategies. It could be shown that with these improvement in therapies, the survival increased and the death rate decreased during the last years. Thus, for the perioperative cardioprotection, the clinical implications are that we not only should describe cellular mechanisms and new targets, but that we have to use adequate animal models, for example, with comorbidities, to describe these mechanisms in animal models, and that we have to use to do proof of concept studies with correct patient selection. We probably need to include the high-risk patients, which were up to now not included in most of the outcome studies investigating conditioning strategies. Outcome studies should have clear definitions of endpoints to allow comparison of different studies with each other. And we should use combination therapies combining different time points, different modalities, and targeting different pathways, cell types, and non-cellular structures to allow cardioprotection in our cardiac surgery patients. Thank you very much for your attention.
Thank you, Chairman, for the introduction, and I would like to thank the organization for inviting me to give a lecture on perioperative lung protection within the webinar of organ protection organized by ANA. I think I can only give this lecture by standing on the shoulders of giants. Those are on top of this slide, the members of the Protective Ventilation Network and members of the Critical Care Asia, two networks that are involved in studies in the operating room and in intensive care patients worldwide. My affiliations are at the bottom of this slide. I'm connected to the University of Amsterdam in Amsterdam, the Netherlands, but also to the Oxford University and the Mahidol University in the UK and in Thailand. And from these positions, I organize and conduct trials, including randomized clinical trials in patients that are undergoing intraoperative ventilation. I have no conflicts of interest with regard to content of this presentation today. Today I will discuss with you the following topics. First, I will explain a bit how ventilation can harm lung tissue, also of patients that are undergoing this intervention for a short period of time, that is, patients in the operating room. I will discuss the impact of post-operative pulmonary complications, a complication that is often seen, and as I sometimes call it, is the ventilator-induced lung injury caused by intraoperative ventilation. I will discuss studies that focus on lung protective measures, focusing on ventilation, and I will discuss the key players that are there, tidal volume and the PEEP level. And I also will discuss some studies that focus now on the driving pressure. Finally, I will provide you with some conclusions. So focusing first on how a ventilator can cause harm in operation room patients. I think there are two players, maybe even three players, very important. First, there is the tidal volume size. From studies performed in patients in the ICU, in particular patients with ARDS, but also in patients without ARDS, we know that it's important to keep a tidal volume adequately low, meaning around 6 to 8 milliliters per kilogram predicted body weight. We know from animal studies, but also clinical studies, that a too large tidal volume can cause harm by inducing overdistension of lung tissue. On the other hand, there is this discussion on the PEEP level, the positive end expiratory pressure. We know that PEEP can keep lung tissue recruited during expiration, and by that improving oxygenation. But we also know that it can cause overdistension. Actually, at any level of PEEP, there is some overdistension. And as you can imagine, with more PEEP, there will be more. So it's best to have a personalized PEEP level in which it helps oxygenation to keep it at an adequate level, but prevent too much of overdistension by using a high or too high level of PEEP. The issue of driving pressure is something I will discuss later on during this lecture, but it's probably also very important to keep the driving pressure low, and in part this can be reached by using a low tidal volume, but also by preventing overdistension by a higher level of PEEP. Postoperative pulmonary complications are frequent. This study, which was a meta-analysis of individual patient data coming from 12 investigations from 9 countries, shows that if we focus on the postoperative lung injury, so that's a very strict PPC, ARDS, we can see that it's not having such a high incidence. Only some 4 to 5% of patients are having this complication. But if we look at the impact of development of ARDS after surgery, the impact is huge. We can see that there is an effect on survival, but also when we look at morbidity, so not only mortality, but morbidity, like in this study, this is an individual patient data meta-analysis coming from 7 hospitals in the US. We can see that it's having an impact on, for instance, lengths of stay in hospital and lengths of stay in the ICU if patients were transferred to the ICU after surgery. This latter study, by the way, showed nicely that one potentially modifiable factor is tidal volume size. So by reducing tidal volume size during surgery, postoperative pulmonary complications could be prevented. What you also can read from this slide, if we use a less strict description of postoperative pulmonary complications, here also including mild postoperative pulmonary complications, which includes the use of oxygen after surgery, which was an unexpected event, it's much more often. Approximately 1/3 of patients are having a PPC. So can postoperative pulmonary complications be prevented? Earlier studies, mainly small studies, showed that if the tidal volume was kept low and a higher level of PEEP was being used as compared to a higher tidal volume and no PEEP, there was indeed a reduction in postoperative pulmonary complications, as was found in this Italian study. Again, this was a small study, only 65 patients, but there was a clear signal that protective ventilation was reducing postoperative pulmonary complications at day 1, day 2, and day 3. This was confirmed in a Chinese study. This study was also small. Only some 60 patients were randomized to a strategy very comparable to the previous slide, a low tidal volume compared to a higher tidal volume, and PEEP versus no PEEP. And also this slide nicely shows that with a higher tidal volume, low PEEP or zero PEEP strategy, there's much more pulmonary complications as compared to the protective ventilation strategy. This was one of the largest studies performed over the last decade. This is the IMPROVE study, a French study performed in 7 hospitals, randomizing 400 patients to protective ventilation or standard ventilation. Standard ventilation at that time being a tidal volume of 10 to 12 milliliters per kilogram predicted body weight and no PEEP. Protective ventilation in this study was defined as using a low tidal volume of 6 to 8 milliliters per kilogram and PEEP between 6 to 8 centimeters of water. And what we clearly see in this study was that there was benefit coming from using a protective ventilation strategy with a reduction in postoperative pulmonary and extrapulmonary complications. The main question that came with this study is, was it the tidal volume size or was it the PEEP level that caused this difference in incidence of postoperative complications? And for that reason, the Provilo investigators investigated whether it was the PEEP level that was explaining this difference in outcomes. So in this study of approximately 900 patients, a higher PEEP strategy was compared to a lower PEEP strategy, in which tidal volumes was kept at 8 milliliters per kilogram in both arms. This study was a neutral study. We did not find a difference in postoperative pulmonary complications with respect to the use of a higher or a lower level of PEEP. And we meta-analyzed the data coming from all these studies, including the IMPROVE study and the Provilo study, nicely showing that it was the tidal volume size that was associated with a lower incidence of postoperative pulmonary complications and not the PEEP level. One question that popped up was, is this also applicable for patients that are having a higher BMI? Because you can argue a patient with a higher BMI might benefit more from a higher level of PEEP than a patient with a normal BMI, and those patients were excluded from the Provilo study. So we performed a Pro-B study showing that if we use a higher level of PEEP compared to a lower level of PEEP, while keeping tidal volume constant at 6 to 8 milliliters per kilogram predicted body weight, there was no difference with regard to the outcome of postoperative pulmonary complications. However, it resulted in more hemodynamic instability in more patients were in need of using or getting a vasopressor and developed hypotension more often in the high PEEP arm of this study. Then the question can be, okay, so if this is effective in patients that are receiving 2-lung ventilation, what about patients that are undergoing 1-lung protective ventilation? Is there also need for using a protective strategy compared to an unprotective or standard ventilation strategy? This was a very recent publication. It's just out, I think, 1st of April of this year, comparing the individual patient data from 5 hospitals in the US, having the composite of postoperative pulmonary complications as a primary outcome. And here in this study, we did not see a difference if we compare protective ventilation, defined as a tidal volume below 5 during 1-lung ventilation, versus above 5, and using a higher level of PEEP compared to a lower level of PEEP. One question here is whether we can easily translate the 2-lung situation to a 1-lung situation or 1-lung ventilation. And also important to realize is that the incidence of postoperative pulmonary complications was higher than expected and was also including endpoints like air leak or pneumothorax, which may not be too surprising in this type of surgery. And you can wonder if this is being affected by the way a patient is being ventilated. Anyway, to give a better answer to this question, the PROTOR study is being performed. PROTOR is a study very much like the Provilo study and the Pro-B study, meaning that the tidal volumes are kept low in both arms of the study in this randomized clinical trial, but the PEEP level is being different between the higher PEEP and the lower PEEP arm. So what's next to tidal volume and PEEP? What about the driving pressure I was already discussing? The driving pressure may be more interesting now to look at, because I think that in most ICUs, tidal volumes are now kept low, and there is this common use of a somewhat higher level of PEEP, or maybe even a high level of PEEP above 5 centimeters of water. The proof network investigators ask themselves the questions, so what happens if you use a higher level of PEEP and this results in a higher driving pressure, meaning there is more overdistension caused by the higher level of PEEP, apart from the positive effects on the prevention of atelectasis. This is an individual patient data meta-analysis from 17 investigations in 9 countries, already published some 5-6 years ago, but it nicely shows that if there is an increase in PEEP, resulting in a decrease in driving pressure, so you could say here in these patients, there is a positive effect on atelectasis and no overdistension, versus an increase in the PEEP level causing an increase in the driving pressure. So here there could be a positive effect on atelectasis, but there is also overdistension. That in the latter, it was associated with an increase in post-operative pulmonary complications. In other words, PEEP can be good, but if it's resulting in higher driving pressure, it is associated with harm. Exactly, this was one of the aims, or maybe I should say reasons, to perform the IPROVE study. This was a somewhat complex study with 4 arms, but in 2 of the 4 arms, it was looked after if a PEEP level titrated to the best driving pressure. Actually, they used the compliance of the respiratory system of that, but that's almost the same. If this resulted in a lower incidence of postoperative complications. And as you can see here in the Kaplan-Meier curve, there is a signal, but the signal was not strong enough. And it could be that this was simply a too complex study with 4 arms, making it not that easy to show that there was benefit. If we now move to patients undergoing 1 lung ventilation, this is a randomized clinical trial coming from Korea. And here we see that the same strategy was not only feasible, meaning that the investigators were able to titrate the PEEP level to the best driving pressure, as you can see here on the right side of the slide. But it was also associated with a much lower incidence of postoperative pulmonary complications, suggesting benefit from this intervention. Actually, at this moment, there are several randomized clinical trials being performed, like the IPROVE 2 study, which is the successor of the IPROVE study, but now again focusing on if it's beneficial to titrate PEEP level to the best driving pressure. The designation study, which is a study performed by myself together with one of the chairmen and a large group of investigators, looking in patients undergoing open abdominal surgery, whether a driving pressure target for PEEP titration is better. The IMPROVE 2 study just started, successor of the IMPROVE study in France, now focusing on the same topic. So is a PEEP level titrated to the best driving pressure better than one in which there is a standard level of PEEP being used? This is in acute surgery patients. And finally, we ourselves will come up with a designation 2 trial, which is focusing on the same topic, but now in patients undergoing closed abdominal surgery. So what are the conclusions from the literature, how I see it? I think it's best at this moment to conclude that patients receiving intraoperative ventilation should be ventilated with a lower tidal volume of 6 to 8 centimeters of water. There is a lot of discussion going on about the PEEP level. Personally, I think that based on what we see in the literature, we should use some PEEP, but we should not use PEEP to have the best oxygenation, but maybe use the driving pressure as the best target. And I'm very much looking forward to the results of the trials I discussed that are now running in the next 2 years or so. I think there will be a lot of new information on this, and where the driving pressure is indeed the new target of intraoperative lung protective ventilation. So here I would like to give the word back to the chair, and happy to take any questions. Thank you so much.
So maybe I get started. So first of all, I would like to thank the speakers for the excellent presentations. And I have my first question for Benedikt Preckel. So you already talked about remote ischemic preconditioning, and you demonstrated that the ERICA trial and the HARD-RIP trial, which was performed in Germany, were negative trials demonstrating that remote ischemic preconditioning didn't have an effect on the outcome. But there is an ongoing discussion regarding the use of anesthetics with remote ischemic preconditionings. Some data suggests that propofol can attenuate the effects of remote ischemic preconditioning. What do you think? And maybe you can also comment on the patient population that was investigated in both trials.
Yes, thank you, Alexander, for that question. It's correct that there is an ongoing discussion, and we still do not really know whether propofol or what the influence of propofol is, whether it really inhibits cardioprotection, because there were a lot of proof of concept studies which for sure regarding volatile anesthetics which used propofol and showed that there is still a cardioprotection. But it has been shown in other studies that propofol might block the cardioprotection that could be established by other interventions. Regarding the patient population, I mentioned in my conclusion slide that we probably have to look at the high-risk patients, and you on your own did a study in Münster, I guess, on patients looking for patients with kidney damage, with preoperative kidney damage, with so high-risk patients, not let's say otherwise healthy coronary artery bypass graft patient. And in those patients, probably organ protection is more relevant than in the normal, otherwise healthy patient. And the problem with most of the outcome studies was that the really high-risk patients with heart failure, with kidney injury before going into surgery, they were mostly excluded. And probably thus those patients who would have the biggest benefit from additional organ protection strategies were excluded from those studies.
Okay. I don't see any questions coming in from the audience. Probably while preparing for some questions by the audience, I would like to pose the question to Professor Meersch. Professor Meersch, if the KDIGO bundle is so effective as you mentioned, why don't we use it for all our patients perioperatively?
Well, Professor Hollmann, this is a good point. The answer is clearly no, we should not use it in every patient. First of all, if you were to apply the bundle to all the patients, you would need a lot more staff, and this would obviously be cost intensive and be a problem for the healthcare system. But much more important is the fact that the bundle is also associated with negative aspects. For example, you need a functional hemodynamic monitoring to optimize volume status and perfusion pressure. And this hemodynamic monitoring is predominantly invasive. While we have newer non-invasive techniques, but these need further optimization and the invasive techniques are more accurate. Let's take, for example, the PICO or the PAC. For this, we need extra catheters, which carry the risk of bleeding as well as vascular injury and can potentially end up in life-threatening complications. So this is not necessary in patients who are not at risk for developing acute kidney injury. And furthermore, according to the bundle, nephrotoxic agents should be avoided, but this is not necessarily good for every patient. For example, the American College of Cardiology recommends introducing angiotensin-converting enzyme inhibitors and angiotensin receptor blockers as soon as the patient is stable. However, in the Prevaki 1 trial and the 2 trial, the use of these medications was avoided for a period of 48 hours to protect renal function. So these and other reasons lead to the statement actually that the bundle should only be used in patients who are at high risk of developing acute kidney injury. And this high risk can ideally be narrowed down by additionally measuring biomarkers in patients who have clinical risk factors for AKI and thus acting in a patient-specific manner.
Thank you very much, Professor Meersch. Probably I can post a question to my co-investigator of the designation trial, Professor Schultz. Professor Schultz, you mentioned that there are several components of lung protective intraoperative ventilation, the tidal volume, probably the respiratory rate, the PEEP level. Don't you think that we should think about some composite point, like, for example, mechanical power to target instead of all these individual components of intraoperative lung protective ventilation?
Well, Marcus, I think that's a great point, and it shows that you are also an intensivist and not only an anesthesiologist, because this is very hot in intensive care at the moment. Indeed, the mechanical power, or nowadays we tend to call it the intensity of ventilation, is a sort of summary variable or parameter, if you like, consisting of aspects like tidal volume, respiratory rate, and the pressures being used, the driving pressure, and maybe also the flow, but we are not sure if we really should incorporate that. And what we see in the ICU setting is that a higher mechanical power or intensity is associated with a worse pulmonary outcome. So yes, I think we should combine those factors. And why I say this, because when I'm at the bedside of an ICU patient, I can of course lower the tidal volume, but as a price, I may have to rise the respiratory rate. And what is causing more harm? What is causing more energy in a patient? And this can be nicely captured in mechanical power or intensity. And as we speak, actually, just this afternoon, we decided to go back to the ProVilo and the ProBeast trial I discussed in the lecture, because we have all the data to calculate intensity in these patients to see if a signal that comes from mechanical power or again intensity is stronger, having a strong association with outcome. And the other nice thing is that you can put this variable actually through an algorithm on your ventilator. You can give it as a number. Then, of course, the question comes, what is good and what is best? What is the cutoff that you should use? So I think there's a lot of studies still needed, but this is certainly a way we have to go. And again, when you look in intensive care, many people are now thinking ahead, like maybe we should more think of intensity and mechanical power than just that silly, simple tidal volume or respiratory rate.
Thank you very much, Professor Schultz. There is some question coming in from the audience, and it pertains to your answer. And the question that was posted is, what is the optimum driving pressure value for the intraoperative setting?
Yeah, I think that's a great question. Let me go back again to what we have seen in the intensive care. There we think or assume that the driving pressure of 15 centimeters of water is acceptable. But we have to realize that these are sick patients, so maybe the driving pressure should not only seen as something we cause per se by mechanical ventilation, but it's also a biomarker of illness of the lungs. And frequently these patients, of course, are having sick lungs. Is the driving pressure, is there a cutoff that we can give for driving pressure in the OR possible? I'm not sure at the moment. The problem here is also that it depends maybe on the type of surgery. For instance, if you do abdominal surgery, open abdominal surgery, or closed abdominal surgery, with closed abdominal surgery, you have a higher intra-abdominal pressure. So it could very well that it translates in another driving pressure to use in these patients. And the same could be true about intrathoracic surgery or one lung ventilation. If you do this with an open chest or a closed chest, of course, this will have an effect. So the short answer is, very good question. Actually, we don't know, and this needs much more research in the near future.
At that moment, thank you very much, Professor Schultz. At that moment, there are no more questions from the audience. So I would like to hand over to my co-moderator, Professor Zarbock. Professor Zarbock, any more questions to our speakers?
I have a question for Melanie Meersch. So not everybody has access to these new biomarkers, but can we also use different risk factors which are available and evaluated in different clinical scenarios to identify patients at high risk for AKI?
Well, that's true, of course. Not every clinic has the new biomarkers available. One can use clinical risk factors, and there are some risk scores, such as, for example, the TACA score for patients undergoing cardiac surgery. And the higher the score, the higher the risk of developing dialysis requiring AKI. However, this is a relatively large number of patients which will be then included and where the bundle will then be implemented. And this means that more resources, staff as well as money is needed to provide optimal care for all these patients. And biomarkers actually can be used to further narrow down the patients who will develop acute kidney injury. And the other thing is that for other settings outside the cardiac surgical setting, we need better clinical risk scores.
Thank you.
Okay, I don't see any more questions from the audience. I also would like to thank the speakers. And I might summarize what I have learned from this webinar. So first of all, regarding renoprotection, we learned from Professor Meersch that a biomarker-based personalized strategy using the KDIGO bundle is probably currently the most effective way to prevent acute kidney injury in the perioperative setting. What I learned from Professor Preckel is that conditioning of the heart is still alive for our patients undergoing cardiac surgery, but also for other cardiologic interventions. But that we have to figure out which patients will benefit from which intervention. And from Professor Schultz, I learned that post-operative pulmonary complications occur frequently, and that they are of clinical relevance, and that it is worth preventing them. And next to focusing on tidal volumes, we have to keep them low, as I understood, and PEEP. And maybe I summarized that in a pretty provocative way, is that we only should use PEEP if we need it for sufficient oxygenation, but that it would be better to target either driving pressure or total energy to the lung the mechanical power. So these are my take-home messages from this webinar. And again, on behalf of my co-moderator and co-chair, Professor Zarbock, I would like to thank all the three speakers for their excellent presentations. And I would like to thank the audience for listening to our webinar. And I hope that you learned as much as I did. And yeah, I wish a nice day, or for the Europe, a nice evening. Thank you very much.
Thank you very much. Have a good evening. Bye.